Hello, good morning, and welcome everyone to today's Cancer Survivorship Echo series. We're going to be hearing from Mary Ann Brown. Mary Ann Brown is an RN, MSN, and the Director of Palliative Care at Renown Regional Hospital. Mary Ann has over 30 years of progressive leadership in public and private health and human services, most recently with hospice and palliative care. Mary Ann is a certified health ethics consultant, certified hospice and palliative care administrator, and a member of Nevada's Palliative Care Council. We're so grateful to have her as our presenter today on Advanced Directives and POLST. So welcome, Mary Ann. We'll go around the group here as well and have everyone introduce themselves so we can find out where you're from and who you are. So Bridget, you want to start us off?
Good morning, everyone. This is Bridget, Programs Manager at Nevada Cancer Coalition.
Thanks. And Dr. Barry Cole, are you there? All right, maybe Barry stepped away. So we'll go to Nirav Patel. Could you introduce yourself? Go ahead.
Sure. Hi, I'm Nirav Patel, and this is Shelly Williams. We're with UNLV Medicine, and we're just kind of just wanted to watch this conference today because we might be interested in starting an echo hub here at UNLV. So we're just kind of doing our research.
Good. Thanks. Great to have you. Alan, you want to go ahead?
Yes, thank you. I'm Alan Fisk. I do technical support. If you're having some technical issues, please give me a call.
Thanks. And then next is Kay Preciado. If you could take yourself off mute with the icon in the lower left corner of the Zoom screen, we'll be able to hear you. Yep, go ahead. If you have a microphone, we should be able to hear you now. All right, doesn't seem like we're able to hear you, so if you could send in through the chat function your name and location, that would be great. Next, Myra Garcia. Myra, are you there? Can we have you introduce yourself? Okay. Carrie Harrington. Carrie, are you there? Myra Garcia is with Access to Healthcare. Thanks, Myra. Carrie, if you joined us, just make sure you click the icon in the lower left corner and we'll be able to hear you.
Can you hear me?
Yep.
Yeah, good morning. I'm Sherry Glockner. I'm the Director of Care Management at Access to Healthcare Network.
Great, thanks, Sherry. Good to have you.
Thank you.
And then we have Lori Squirtsoff joining us, and she doesn't have audio today, I don't believe. So then we'll go to Denise R. Denise with the Cancer Care Coordinator at Access to Healthcare. And we had Barry Cole right in. Barry is a retired neurologist and psychiatrist and pain management specialist. He was the original trainer for AMA's DPAHC curriculum. And then we had Karina Preciado right in as well, Cancer Care Coordinator at Access to Healthcare. So lots of folks from Access today, great to have you. And then one last is a phone number called in, a 775 area code 772-9720. Could you introduce yourself?
Carrie Harrington.
Oh, that's you, Carrie. Thanks, good to have you.
Thanks.
All right, so we'll open it up right now and see if anyone has any specific patient cases they want to talk about or a general question for Mary Ann this morning. So feel free to take yourself off mute or write in using the chat function.
Good morning, this is Barry Cole. I just want to tell my colleagues down in Las Vegas at the med school, since you're guesting and trying to figure out if this is of your worth your time, the answer is yes. And one thing you should do is avail yourself of the opportunity for case discussion. Just keep it HIPAA confidential, like no real names, but you can talk about case facts. And you'll actually find that on these calls, there's enough smart people who can actually have some good input for you about the specific case at hand, as well as maybe suggestions for academic resources for our Epic Pain Management series. We've actually been sharing articles, we've been communicating with each other offline and kind of helping folks with some of the more challenging management of pain in Nevada subsequent to the passage of AB 474 in our last legislature that we pray will be fixed in this session of the legislature. So don't miss the opportunity to use these meetings as a venue for discussion, and we can also kind of organize some efforts to be more strategic.
Thanks, Barry. So I haven't seen any other questions come in, but it is open throughout the presentation. So yeah, feel free to take yourself off mute or write in using that chat function, and we'll be able to address those. So we'll get going here with the presentation. Go ahead.
So good morning. Thank you for having me. I'm going to be talking about Advanced Directive and POLST, but also more generally about advanced care planning, because it really is not just about those two documents, but really about the process of doing advanced care planning. And as someone who works in the acute environment with palliative care patients on a regular basis, what we find is patients and families that have participated in advanced care planning do much better when experiencing an acute illness or a crisis, a medical crisis. So I'm hopeful that those of you that are providers in the ambulatory care environment really embrace the idea of incorporating advanced care planning into your practice. So let's go ahead. And one other thing I would say is we do a little bit of we call it preventative palliative care with the public. So my team Renown offers 4 advanced care workshops a month to the public for free. My team does 2 of those, and it is heartwarming and very rewarding to see patients and just people who've completed their advanced directives and begun the advanced care planning process. Almost everyone who attends those workshops walks away saying, I feel such a sense of relief. And we stress that they've really given their loved ones a gift by doing this work of advanced care planning. So with that, I'll get started. So, you know, as a society and as individuals and parts and as communities, we do a lot of planning. We talk about birth of children, we plan graduations, our careers, college, weddings. We're planning for a lot of things in our lives, but rarely do we have conversations or plan how we will be cared for at the end of our lives. And of course, it's going to happen to everybody. So incorporating this idea, like other parts of our lives, we really should be planning for the end of our lives. So why should we do it? As I mentioned, providing information on what patients want as they face a diagnosis or approach their end of their life is really important. It improves that decision making, and as I mentioned, probably one of the biggest things is it reduces the stress and anxiety of depression, not only for the patient, but for the family. And it is also another way of providing greater control to the patient. And it's more likely that the patient will receive care and treatment that's in line with their values or what they want if, in fact, there's been some advanced care planning. And contrary to what sometimes providers think, patients really want to discuss end-of-life issues with their doctor. They really want you to have conversations with them about end-of-life and what they're facing. And I get this a lot from providers that, yeah, it's very hard to do. Almost always, the responses I get from providers, particularly in the ambulatory care environment, is that I don't have time. You know, this is not the appropriate setting, etc. But it really is important, and you can incorporate it into your workflow and your standard work in your practice. So the goal is to really start early and focus on goals and having ongoing conversation. Advanced care planning, again, isn't a one-time event. It's not completing an advanced directive and you're done. It's really an ongoing process with ongoing conversations. And it empowers the patient. The goal is to empower the patient. And from a provider perspective, you really want to develop that systematic approach so that you're doing it consistently. And then for those of you that work within some sort of team structure, there are parts of advanced care planning that you can delegate and incorporate your team into helping you achieve that advanced care planning. And again, no better time than now. Again, putting it off doesn't make it easier, and it should be, again, embedded into all the things that we do with patients. So one of the ways to do it, people ask me, well, how do you have those conversations, and what does that look like? Well, it starts with introducing the topic, and most of the time you want to have somebody that's important to the patient with them. So they have a significant other. So if you're having an office visit, it's ideal to have the spouse or their significant other present. And you want to explain why you're raising the topic. Either it's related to their diagnosis or a change in prognosis, or potentially they've had a recent hospitalization. Or a lot of providers are saying, this is a part of my standard practice. I have these conversations with all my patients. Sometimes maybe when you're establishing a relationship with a new patient, you want to bring up this idea that advanced care planning is really important, and you have these conversations with all your patients. And you want to stress that the discussion is really about supporting the patient, whatever their choices are, that it's really about examining what's important to them. And you want to set the stage for the conversation. You want to reassure the patient that their death is not imminent. The minute you bring up some of these topics, patients are very fearful. But certainly if that's not true, you also don't want to give false assurances. And then you want to make sure the patient really has an understanding about their illness and prognosis. In palliative care, when we focus a lot on establishing goals of care and plans of care, we spend a lot of time asking the patients and families what they understand about their illness and prognosis. So just by asking that basic question, tell me what you understand about your illness, tell me what's going on with you, you'll get a lot of information from that very first question. And then you want to explain and discuss any treatments, and you want to do that in a way that is focusing on the patient's experience and probable outcomes. So try to avoid as much as possible using the jargon that we use in healthcare that we're so comfortable with. Oftentimes when I'm talking about what's important to the patient, I'll use statements like, would it be important for you to be able to eat, to be able to walk, to be able to interact with your loved ones? So you're really finding words that have meaning to your patients so that you can understand, again, their values and why they might be making certain choices and expressing certain preferences. And so the next part is about eliciting those preferences. And so this should be a back and forth discussion about specific treatments that you want to describe to the patient and make sure they understand, and they're relating those again to the patient's values. Again, it's finding ways that you can connect to that patient and understanding, again, why they would make certain decisions. And then identifying what situations the patients would find unacceptable. Some patients will say, I don't want to be kept alive on machines. Or I had a family member who had tube feedings and that's unacceptable to me. I want to be able to eat. Or I really want to avoid being in a nursing home or being dependent on others. So you want to discuss the probabilities in the medical treatment. Here's things we can do for you, and here's the possible outcomes for those. And you want to give a clear description of what you will do to meet the patient's goals, regardless of the choices they make. So even if you have a patient who's saying, I'm not interested in that kind of treatment, you want to emphasize that the alternatives and the support they will receive. One of the most important things for the patient to do is identify that proxy. The person who will speak for them when they're unable to convey their own preferences. And you want to stress the need to make sure that the person they're selecting knows the patient's values and goals and what they would choose. When I do the advanced directive workshops, I tell people that who they pick is critical, and that it doesn't stop with just saying, this is my proxy, my agent as identified in my advanced directive, that there's ongoing discussions between that patient and their agent, so there's an understanding. The agent should feel like they're making choices the patient would make, not that they're being burdened with making decisions. So those patients, if the patient and the proxy have done a good job of talking about things, that agent again should feel relief that they are just voicing the decisions that the patient would make for themselves. One of the things is Don't pick someone who says, I could never make those decisions. And again, I also tell people it's important to do a durable power of attorney for healthcare and identify that proxy, especially if your next of kin, your legal next of kin, would be the person you would not want to make decisions. What we find in the hospital is people without advance directives, particularly individuals who haven't identified an agent. We may be talking to an estranged spouse to make decisions. We may be talking to siblings who haven't seen their brother or sister in many, many years. And so the quality of those decisions is going to be not as good as someone who understands what's important to that patient. And then it's all about documentation. Whatever system you work in, whatever environment, you want to really talk about, summarize the conversation that you've had with the patient, clearly stating the goals that were discussed and any decisions that were made or those that are pending. And then that would be, and this process, again, can be over multiple interactions with the patients. Oftentimes, during that initial discussion, patients won't be willing or able to complete their advance directives. They're going to need to think about it. And in fact, that's better if they go away and think about who would they select as their agent, what's important to them. And then you would come back at some point and complete that advance directive or POLST as appropriate. And then you want to close the conversation by really expressing an appreciation for the willingness to talk about the topic. And then also that even if the patient has selected maybe to forego some treatments, that you're really not going to abandon them. You're going to continue to work with them and provide care. And to stress that this is a process. It's not a one-time event. And they're going to continue to think about it and make changes over time. Oftentimes you'll see someone who's completed their advance directives, let's say as part of their estate planning, and then 20 years later they're coming back and saying, gosh, it's really different. I was in my 30s or 40s when I completed that. Now I'm in my 70s or 80s and I have different thoughts about what I would want to see at the end of my life. Or there are different people in my life that I would want to make decisions for me. So some general tips is really it's about asking questions initially. You'd be surprised asking a question, as I mentioned, tell me about your health or tell me what's important to you will really get you a lot of information if you just listen and ask the question and then listen. And then reminding patients that they don't have to make immediate decisions and that they can change their minds over time. And they understand the conversation by asking why when they're asking about certain treatments or expressing their goals. I had a family member the other day who said, we had a patient who was on comfort care and dying in the hospital. And the sister said, I want this patient to have Lasix, continue Lasix no matter what. So when I asked the question why, she said, I had a brother who had leukemia who died drowning in his secretions. So it's really important for me that you're pulling all that fluid off of this patient's lungs. And so once we knew that, there was a different discussion we could have with this family about why they were requesting certain treatments. So why is a very powerful question, particularly if you're not understanding a choice that a patient or family member is making. You also want to restate your understanding so that you get it right. Summarizing at the end of any discussion, any advanced care planning discussion is critical because it's a way of making sure what you thought you heard was in fact what the patient was saying. So then the two of you or the group of you leave that conversation with the same understanding. And it's important to talk about positive things that you can do to help the patient accomplish their goals. Oftentimes we're talking about things we won't do or the patient doesn't want us to do, such as resuscitation. Then you also want to talk about things that you will do. In the hospital setting, when we're talking about moving the goals of care to comfort, I often say we're giving up aggressive treatment, but providing aggressive care. So you really want to emphasize those positive things you will be doing for the patient and family. And then try to avoid vague terms or at least define those things again so the patient and family understand. There are lots of tools out there that can help you and help patients and family be prepared for advanced care planning. Again, one of the techniques that some offices and practices establish is that advanced care planning for all new patients or at the beginning phases of treatment. So if you're a specialty provider, you might say, when we get a referral of a new patient, we always start with Do you have an advance directive? Let's begin to talk about some advanced care planning. There are other tools out there, the Conversation Ready toolkit that's available online. You just Google Conversation Ready. They have some really great toolkits. Then also the toolkits are very specific for different languages. There's those for dementia, so they also have some that are disease specific. And those are guides to really help patients and their loved ones have that conversation. You want to schedule an appointment to review or discuss the patient's preferences and who that surrogate decision maker would be. And then depending on how you fit it into your practice, you might give them a packet and encourage them to complete it and bring it back, or have them attend a community workshop such as the ones that we give at Renown. If you're going to do advanced directives in your office and have your team help with that, there's some things to remember that the POLST is the easiest one to do because you can sign that as a provider and the patient or their next of kin surrogate can sign. The advanced directive, and we'll go through the details, requires witnessing, so that you may need some, or a notary, so you may need to do some things in your practice environment. The original document should always go with the patient, and then they should be embedded into whatever EMR system that you have. So one of the best things, I think personally, that came out of some of the Affordable Care Act work was the billing for ACP. So providers, as of January 1st, 2016, can bill for advanced care planning. And you can bill, there's two billing codes up there. They are time specific. The great thing about these billing codes is you can have, if you have multiple conversations with patients over time, as long as you're changing the plan or there's been a change in condition, you can have multiple opportunities to use the billing code. So for someone who has a chronic illness or their circumstances are changing, you can again bill multiple times over the course of a year. It can be billed in the hospital again or ambulatory. There's no specific diagnosis required, and there are no place of service limitations. So again, these billing codes are open to everyone who engages in advanced care planning with patients. So I'm going to talk a little bit about the tools that you can use for advanced care planning. We'll talk about briefly living wills, or in Nevada we call those a declaration, and then the durable power of attorney for healthcare, and then I'll review the provider's orders for life-sustaining treatment. This is an older slide of mine, but we now have provider's order for life-sustaining treatment. We were able 2 sessions ago to expand the ability to complete POLST, so it's not only physicians, but APRNs and PAs can sign POLST forms. So advanced directives, as I mentioned, do 2 things. They identify the person that you would want to make choices or make medical decisions when you can't make them for yourself. And they discuss what choices you would make in advance. So again, in Nevada, the living will is called a declaration, and it has general statements to the physician or to the providers about what kind of medical care a person would want, specifically related to end of life. Most states have some sort of living will statute. The forms vary a little bit, and most states honor other states' living wills. There is generally some statements in there again about life-sustaining treatment, life-prolonging measures, and artificial nutrition and hydration. Oftentimes, I'm recommending that a person do a declaration if they don't have someone to name as a proxy or an agent, because this direction is given, again, directly to providers. So a durable power of attorney for healthcare is the second form of advanced directive in Nevada. And it's a legal document that names a person or agent to make medical decisions when the person is unable to make them for themselves. And the person that's identified as the agent has a duty to act consistent with the desires stated in the document. So again, that's why it's critical that the person the patient selects really can get on board with the decisions the patient wants. So again, if you have a loved one, a significant other that says, I could never remove my wife from a breathing machine, and the patient has selected not to have life-sustaining interventions or treatment in certain situations, that may not be the best person to make those decisions. And the other reason this is important for us too is that So in the hospital, when we're utilizing these documents, if the agent is saying something that's contrary to the statements of the patient, we're really going to explore why and remind them of their duty to act consistent with what the patient's wishes are. And again, individuals continue to make all medical decisions for themselves as long as they're capable. So this advance directive really does not come into play until that patient lacks capacity. So as long as the patient has capacity, they'll continue to make decisions. And then patients can identify a first and second alternate. I usually recommend at least one. So if the primary agent isn't available, there's someone sort of in the wings waiting to help with decisions. And then you want to make sure those alternates have the same sense of understanding that the primary agent has. One of the things that happens with advanced directives, sometimes people will do them in a vacuum. In other words, they do it as a part of their estate planning. And where do they put those documents? In their safety deposit box in their bank. So how helpful is that? Oftentimes we're saying, patients are saying, or families saying, yeah, I know we had those documents, they're somewhere. So I tell people these should not be a secret. You need to give copies to the agent you name. You need to let your family know that you've executed an advance directive. And then you need to give copies to your healthcare provider and facilities. You know, it's surprising to me, but sometimes there'll be an agent who's been named who didn't know. I didn't know that my sister named me. And that's not a good situation either, because again, the quality of those decisions are going to be based on the interactions that they've had. And if they've had none, it's not terribly helpful. Again, back to in executing them, the declaration can be witnessed by any two adults. So any two individuals over 18 can witness a declaration. So for example, in your office or in your practice, you could have any one of your staff sign those declarations or living wills. The challenge with the durable powers of attorney for healthcare is that they can be notarized, but you have to have someone available that's a notary. You can also use two witnesses, but there are restrictions on the witnesses, and it cannot be a treating physician, anyone who works for a treating physician, basically anyone in healthcare. And then it also can't be the agent named. So oftentimes you might have a patient and their spouse. The spouse is the one named. They can't be a witness. And then one of the witnesses must be unrelated to the patient. So this is why in our workshops we use a notary, because it makes it much easier to make sure we're able to execute those documents. And one of the things to remember too is that these advance directives can be verbally revoked by the patient. They can change their mind. And so particularly when a patient is admitted to the hospital with an advance directive, they can say to us, you know what, I've changed my mind. And we would revoke that document and note that in the medical record. In addition, if there have been several documents over time that have been executed, we're going to look for the document with the most current date or the most recent date, and we're going to be using that document. And again, as I mentioned, most states honor other states' advance directives. I do tell people that it's really important, if you can, to execute the documents in the state where you reside for most of your time, because it's going to be compliant with the laws of that state. So one of the things before we move on to POLST, did I skip a slide? I didn't put the detail in here, but the other component of the durable power of attorney for healthcare is the statements of desire. And there's 5 statements of desire. And when you're reviewing those with patients, it's really important to make sure what they're selecting is congruent and they understand. The first statement states that basically the patient wants everything done regardless of quality of life. So as you can imagine, most people don't pick the first statement of desire, although I certainly have had patients do that. And the rest, the statement 2 and 3 are really about patients who are in a coma or have a terminal or irreversible condition that, and states they don't want life-sustaining or life-prolonging interventions in those situations. And usually what I tell patients about what are those life-sustaining, life-prolonging treatments, those are things you would find in an intensive care unit. And I use simple words like a tube that we would put down your nose or your throat and then attach you to a breathing machine. So if you sort of use words that really allow patients to picture what it would be like to be in an ICU, they're much more able to relate to those two statements. And then 4 is really about artificial nutrition and hydration. And the same statement appears in the declaration. It's probably the most difficult to explain to patients. The advanced directive documents are based on straight from the statutes. So sometimes the language is disturbing for patients as you're going through these documents. Statement 4 talks about dying from starvation and dehydration if we stop artificial nutrition and hydration. So I'm always very careful to say to patients that that's artificial nutrition and hydration, which means tube feeds and IVs. We're always going to let patients eat and drink. And so that's a very different process. So talking about the difference between eating and drinking and artificial nutrition and hydration can often help people understand that 4th statement and the desire. The 5th statement is really about burdens and benefits of treatment and basically asking the agent to consider the relief of suffering and the restoration of function, preservation of function. So oftentimes people are selecting statement 2, 3, and 5, which basically says, if I'm in a terminal irreversible condition, I do not want life-prolonging, life-sustaining treatments. I should have had a slide with those statements in there, but I have them memorized, as you can tell. Okay, so let's talk about POLST. Providers' orders for life-sustaining treatment. I worked with a group for 17 years to try to get POLST in Nevada. So we're really happy that we eventually got POLST. And then again, we went back to the legislature a couple of sessions ago and were able to make, I think, some good changes to the POLST form to improve its effectiveness. We also worked with the POLST Consortium, which is a statewide, national group that really looks at best practices to make sure that POLST forms across the country are really, again, following in line with best practice. So the POLST is providers' orders for life-sustaining treatment. It is very bright pink. Intentionally, it's pink so that it catches the attention of particularly EMS for patients who have executed a POLST and want those orders to be followed in the home setting. And it really communicates orders regarding life-sustaining treatment. These are orders. So this is informed consent between a provider and a patient. Generally, it's for decisions related to resuscitation, and there's also a section that you can identify the goals of care. So the first section, let me see, do I have sections? No. So the first section is really code status. So does the patient want to be a full code, or do they want to be a DNR, or do not attempt to resuscitate and allow a natural death? So a patient can select code status on this document. The next section is then about, again, the goals of care. So we're looking at, that's actually an old one.
Okay.
That's an old one. Sorry, he's just pulling up the POLST form. It's actually the older one. The newer one just, there we go.
Okay.
Yes.
2 pages.
Yes.
Okay.
So the second section is really about goals of care. So are you wanting full treatment? Again, oftentimes patients are picking attempt resuscitation and full treatment together. As you might imagine, that's not terribly helpful because that's what we would do for any patient who hasn't made decisions. So oftentimes patients are using the POLST form for a do not resuscitate order. And then some are electing selective treatment, and then those that are generally in hospice or have really made some decisions about limiting aggressive treatment are selecting the comfort-focused treatment. And then there's another section, the next section really talks about artificial nutrition and hydration and gives you options there. The nice thing for us in the acute environment is that capacity determination, it can be noted right on this form. When you do an advanced directive in any kind of facility, you're required by statute to do a competency determination, which again is really capacity on a separate form. The POLST has it right there. And then there's a spot for the provider to sign. You have to sign it and include your license number. And then there's a spot for the patient to sign, or in the case of a POLST, it can be the agent on their advance directive. It can then be legal next of kin, all the way down to someone who understands the patient, say a friend, if someone is unrepresented or doesn't have a legal next of kin. The other nice thing about the POLST form is on the back side, if you forget the order of who can sign, it's listed in the instructions. So if you look at the instructions on the bottom section, it's really going to help you complete that POLST accurately. And then on the top of the second page, if you want to, that's where you would note if the patient has an advance directive, particularly if it's the agent signing the form. You want to note that you've seen that advance directive and that it's the agent that's signing the form. You can also note if there's a guardian and that's the person signing the form, or if it's a healthcare surrogate because there is no advance directive, then you would note the relationship to the patient. And it may be that it is a friend because, again, they don't have any next of kin. Then there's also the ability to summarize whether or not the patient has submitted their documents to Nevada Lockbox. And then also you can note the patient's organ donation status. This is not consent for organ donation. This just reflects if the patient has elected organ donation, say on their driver's license. Okay, that's the POLST. I think I just went to questions after that. Yeah, the biggest thing about the POLST is those orders are going to be followed by any provider in any healthcare setting. So if we have a patient in the hospital who's made some decisions with their provider team and they want to elect to be a do not resuscitate, we can complete a POLST form, sign that, we give the original to the patient. So in a home setting, emergency personnel should follow those orders. The patient, for example, goes to a skilled nursing facility, they should also follow those orders. On the flip side, when we receive a patient into the hospital that has a POLST form, we want to make sure that we're following those orders, even if they are written by a physician that doesn't have privileges, that isn't a part of the organization. One of the nice things about the POLST statute is that it really provides a lot of protection for providers and for clinical team members who are following those orders. Again, the POLST different from an advance directive in that these are physicians' orders to be followed. The advance directive talks about what the patient's wishes are that then the provider turns into orders. So I oftentimes talk about the progression of advanced care planning. It might start again with discussions with the patient and encouraging them to talk to their loved ones. You may execute an advance directive including a durable power of attorney for healthcare. And then as that patient's disease progresses or they age over time, oftentimes, particularly if the answer to the surprise question would be no, I wouldn't be surprised if the patient died in the next year, you want to be considering having that discussion about a POLST form. So I want to leave plenty of time for questions because I presented a lot of information. So hopefully you have a lot of questions or cases or things you might want to discuss.
Yeah, so it's open right now, so please feel free to take yourself off mute or write in using the chat function. If you have any questions, comments, anything like that.
I have a question. So is this something that a patient should keep on them? How is the POLST tracked? Is it tracked through an EMR system, or is it something that, you know, a family member should present to whoever is taking care of that patient?
Yeah, so, I mean, it's not a fail-safe. It's not like a tattoo or a button that you wear. So really it's intended, and it has to be, it's for medical providers. So it's not going to cover every single situation. Often people will say to me, well, what if I collapse in the street? Well, unless you have your POLST form in your hand, REMSA or EMS is going to do what they do. But the idea is that, again, you and your physician have come to some decisions about your care and treatment. So you want to have that, make sure that you bring it to the hospital, or that you've provided a copy to the place that you receive care and it's been scanned in, and that you keep it in the home setting. Most people will put it on the refrigerator or keep it next to the bed. And again, you want to make sure the family knows to say to emergency providers, hey, my husband has a POLST form, here it is. So again, you want to do some instruction and training about how to use that POLST form for the patient and family.
Thank you.
Sure. I would just say I find that in the ambulatory care environment, the POLST form is easier for people to do than the advanced directive, because as I just mentioned, we do an hour workshop on executing an advanced directive, which is impossible to do sort of for a provider to do. I think some practices have been able to figure out providing the documents in one visit, answering questions in another, and then sort of spreading it out over time. But the POLST form, I think, especially if you've come, again, you have a clear plan of care with your patient, you can execute that, in a visit, because it's fairly simple to fill out and to sign.
I do have another question. Is this kind of standard of care? And I'm sure it, depends on provider, but especially as people are aging, such as, I have a grandfather that's 93 years old and my grandmother's 87. I don't think their physician has ever had a conversation with them about POLST or an advanced directive. So I'm just wondering, is there any type of, kind of standardization of like, okay, once someone's at a certain age, you kind of, it would be good to bring these things up?
Yeah. I think, completing an advanced directive for, almost anyone is a valuable tool, particularly as you age, because again, that surprise question, or you want to be prepared. So again, it's about the dialogue, the conversation, then executing the documents. And then as disease progresses or their age progresses, then you want to consider the POLST form. I encourage and have people advocate for themselves with their provider. So they come to the workshop and they've done their advanced directive and they say, oh, I'm really interested in a POLST. I'll say, go back to your provider and have that discussion. Ask them what they think about it. Oftentimes people will say to me, well, I can't bring this up to my elderly parents. I don't know how to do this. How do you bring up this topic of doing this advanced care planning? Well, there are, multiple ways of engaging people in the conversation. One is, things that happen in the media when we have Barbara Bush's experience, the death of celebrities oftentimes brings up the topic of death. And so then you can talk about, we really don't have any plans in place, or we really haven't had these conversations, and I think we should. Or if you have someone who dies in your family or a close friend, again saying, gosh, look what happened in the case of, Aunt Sally. That didn't, they really struggled. Maybe we should talk about what's important to you. The workshops are also have been very helpful in physicians have been sending their patients and saying, I really think it's important for you to do this planning, so I'm going to send you to this workshop. So again, finding ways where you can introduce this topic to your patients, because the benefit is that they are going to receive care in line with their values, and those families and loved ones are going to have a much better experience when that person starts exhibiting or experiencing those medical crises.
And then one other quick question. Are those workshops open to everyone?
Yep, they're free to the public. You can register by calling 982-RSVP, or the website is the same. And you can sign up for them free. We have a notary that comes. If you're a renowned patient, we will scan your documents into the EMR, into Epic, and we will help you complete the application for the Nevada lockbox. I didn't mention that in detail in this presentation, but Nevada lockbox is an electronic repository for your documents. So you fill out an application, you mail it in with a copy of your documents, and then you receive a card back that you can put in your wallet, so that wherever you're at, those documents can be accessed over the internet. And we encourage patients to do that, especially if you're traveling and somewhere, your family can say, oh, her documents are in the lockbox and they can be accessed. Or if you find a card in a patient's wallet, you can access those documents.
Wonderful. And that lockbox, that is for kind of all documents?
It's for any advanced care planning documents. So you could put a POLST form there. You could put a durable power of attorney for healthcare. You could put your declaration. You can put anything that's related to advanced care planning.
Okay. Thank you.
So a couple of questions that have come in here through the chat. So Dr. Palmer joined us a little late today. So a question about if POLST can be accessed, is it local, statewide, or nationwide?
It is, so POLST as a program is nationwide. Each state, there's some variability in states. Some states it's a part of statute, like you find in Nevada. In other states, it's become part of just standard practice. So they look a little different, and they're sometimes called most medical orders for life-sustaining treatment, post. So they're sometimes the forms are labeled a little differently, but the general intent is the same, that these are medical orders to be carried out in any environment.
And if a patient were traveling, say, is the lockbox the best place for, if they were admitted to an emergency department or something like that, would the lockbox be the best place for? Yeah,
the lockbox, again, for when you're traveling, yes, because you could say, my loved one has an advanced directive, and here's how to, you can access it through Nevada's lockbox. I think, we're becoming more and more, everything's more related to IT and technology, so it prevents you from having to carry those documents with you. So yeah, it would be very valuable, particularly if you travel a lot from state to state.
Question about the workshops. Are they available in Spanish?
Yeah, I had that request from a recent workshop. So I'm trying to identify someone who could teach the workshop in Spanish. The POLST form has been translated into Spanish. It's really used for educational purposes because the actual POLST needs to be in English so the orders can be read more easily. So there is a POLST education. The document has been translated into Spanish, and that's available on the POLST website. So I am working on putting together some Spanish workshops because I think it's critical.
And then is there a charge for using the lockbox?
Nope, the lockbox is free through the Secretary of State, Nevada Secretary of State. So you just mail in your application with a copy of your documents. You'll receive a card back in a couple of weeks. When individuals come to our workshop, we actually pay for the postage and mail if they complete their application, we will mail it in for them.
You mentioned having a healthcare advocate in terms of if there is no friend or family member. Please discuss more, especially if an individual is not plugged into the healthcare system.
Yeah, so let me see that. I'm missing. So it's fairly sad. In the hospital, sometimes we will see patients who are unrepresented. I had a patient the other day who had lived for 18 years in an apartment complex, so people knew about him, but they didn't know him. He didn't have a roommate. There weren't any friends that visited. When we did a next of kin search, because we do these internet searches if we can't find family. So we did an exhaustive search to find someone who was related to this patient, and we could not. So unfortunately, there are people out there who are not connected to anyone, which then makes it very difficult for us when a patient is admitted and they lack capacity to figure out what their preference would be and what we should do in regards to medical decisions. So if I, again, tell people that if you don't have a loved one or someone who can make decisions for you, really work on that. But if you're not able to, again, that declaration is helpful because it's giving guidance to your providers about things that are important to you. Most institutions, if we end up with unrepresented patients, we're using ethics committee and we're using other things to help us figure out what we should do for a particular patient.
Thanks, great question.
Mary, this is Barry Cole. Thank you very much for your presentation. one question I wanted to ask was the dilemma that families involved with hospice are being formally told, in effect, correctly, don't call 911, call the hospice at the time of your loved one's passing. But so many other people just clearly don't understand that when a POLST is in effect, there's no point calling 911. It's going to complicate things. And I guess it begs the bigger question, what can we do to get people to programs, hospice programs, where they might actually make a difference? It's so sad when someone's admitted the night before they die versus a couple of months of time on program. And at a national level, we're just not getting people to appropriate hospice care.
So I think, again, if you're doing good advanced care planning with patients and families, it really lends itself to having the discussion about hospice. So if you are talking to someone who, again, meets the criteria for hospice, and you've been having ongoing conversations with them about the progression of their disease, then it really opens up that discussion about hospice. The reason POLST forms are helpful for hospice patients is that not all hospice patients are DNRs. It's generally most of them are, but you can't make a hospice patient be a do not resuscitate. So making sure that those decisions have been clearly identified. You also cannot make patients complete a POLST form. All of these things are voluntary. The POLST form is voluntary, an advance directive is voluntary, admission to hospice is voluntary. So again, all these things are of benefit to the patient and family, so it's a part of that dialogue, that planning, those discussions. So I think if we did a better job of advanced care planning, including talking about end of life, including talking about the gold standard being hospice, and that families can provide hospice care to the loved ones at home, we would see those rates of hospice admission increase. My team, on average, we see about 8 to 10% of all acute admissions for Renown between Regional and South Meadows, and about 30% of our patients elect hospice. So again, I think it's about the quality of the advanced care planning and the discussion so that patients and families really understand what hospice provides and the advantage of hospice for those patients who are terminal.
Follow-up question here from Dr. Palmer. Could you explain declaration, especially declaration before becoming a patient?
Yeah, so a declaration or living will can be completed by anyone. Durable power of attorney for healthcare, the declaration living will, those advanced directives can be completed by anyone. The quality of the completion, I think, depends on who the patient is or person is talking to when they execute those documents. You don't need a lawyer, you don't need a workshop, you don't need anyone. Those documents are available on the internet. People can pull them up, execute them, have them witnessed or notarized, and those become documents. Again, I think the quality of those documents and the choices patients made are often based on discussions with providers. You know, it's not very helpful to get a document where they've selected all the statements of desire, because they are conflicting if you select all of them. So again, I think the quality of those documents depends on the assistance that the person is getting. But someone can execute a declaration at any point. They don't have to be a patient.
So if the person's unconnected, who would co-sign?
Co-sign, I'm not sure.
The declaration.
Yeah, so a declaration, you have to have capacity to execute advance directives. So if a person doesn't have capacity, you can't execute a durable power of attorney for healthcare or a declaration. That patient has to be able to sign. You could execute, the family members or loved ones could execute a POLST with a provider if they wanted to. So, so I'm not understanding that question. I hope I answered that. Still going to the person is unconnected. Yeah, if a person doesn't have anyone to make decisions and comes to the hospital and loses capacity, we're going to do an exhaustive search to try and find someone who knows this patient, someone who's related to the patient, or then someone who knows to help us with decisions.
Okay, so if their capacity is okay, but there's no family member or friend.
Yeah, if a patient has capacity, they're always going to make decisions. If they have capacity and want to execute a declaration or living will, they can. If they have no one to select as their agent, that's probably when they're good. So they're not going to do a durable power of attorney for healthcare. They're going to look probably at that declaration as a tool.
Okay, so we've just got a minute or two here left, so I want to get a question about if you could tell us more about the Palliative Care Council.
Oh, nice. So in the last legislative session, I think it was the last one, the Nevada established a Palliative Care and Quality of Life Council, and members of that council are appointed by the Director of Health and Human Services. And the goal of the council is really to promote palliative care and to do education to the public, to providers about the importance of palliative care. So we have a website. There's a website that's with the under the Department of Health and Human Services about palliative care, and we're really working on doing education so that, again, people are aware of palliative care, the advantages, and also that organizations and providers become aware of the advantages. So not only the public, but those in healthcare.
And then Bridget, did you want to talk a little bit about the summit?
Yes, first off, I would like to thank Mary Ann Brown. That was such an informative clinic, and learned lots, so thank you so much. So these Project ECHO series are brought to you by the Nevada Cancer Coalition in collaboration with Project ECHO Nevada. The goal of the whole cancer survivorship series is really to focus on issues in cancer survivorship in a primary care setting. So one thing I would like to say is that we have our Nevada Cancer Control Summit coming up. So please mark your calendars. It's September 16th, 2019. So this year it will be in Reno at the Whitney Peak Hotel. The Nevada Cancer Control Summit, it's a one-day statewide conference featuring presentations on targeted topics across the cancer spectrum. So please visit our website. We have a lot of really wonderful tools. You can also find a little bit more information about advanced directives and POLST on our website as well as forms to download. So thank you so much, everyone, for attending, and especially thank you to Mary Ann Brown for presenting.
Yeah, thank you, everyone. This was a great session today. So we'll be back in 2 weeks. That will be Friday, March 22nd, again from 8 to 9 a.m. And we'll be talking about the importance of tobacco cessation during that session. So hope to see you then. Thanks, everyone.
Thank you, Troy.